We have the pleasure of welcoming Professor Arnott to come and talk to us, who's here representing the Cheltenham Labour Party on this occasion. And Professor, just so that just give you a bit of a remit for how you obviously been here watching what's just been taking place. So the remit is that you can say anything you want to, essentially. Talk about what you want to, and what the panel will do is that if there's areas for topic they want to explore with you, they will obviously explore that, ask questions, discuss. Okay, so when you're ready.
Okay. Right. Right, glasses. Thank you very much, Mr. Chairman. I can perhaps start with introducing myself. I'm Professor Robert Arnott of Cheltenham, but I'm also a Fellow of Greenhampton College in the University of Oxford, where I teach and undertake research mostly in global health policy, but I know a fair bit about UK health policy. But on this occasion, I speak exclusively on behalf of Cheltenham Labour Party. I'm grateful to you for the opportunity to make this statement as part of the public engagement exercise on the future of hospital services in Cheltenham and Gloucestershire, outlined in the Fit for the Future document. I shall principally address my remarks, or my preliminary remarks, around the issue of A&E services in Cheltenham and the rationalisation of general surgery, a matter of which I have particular interest, but also some general comments concerning the future of NHS, future of the NHS locally. Before I start with A&E services, I want to say one or two things about the engagement exercise itself. I strongly believe, as I'm sure you all do, that openness and transparency should be the very heart of every NHS organisation and service. For this engagement exercise to work, I must be able to go away for today and elsewhere assured that nothing is yet agreed, and that those who participate in today's exercise, or members of the public who respond to the engagement exercise, are doing so in the knowledge that they can influence the decisions. Now, I was going to talk at length about accident and emergency services, and I shall to some extent, but yesterday afternoon when I was sitting preparing this document, I received a phone call from a colleague who's a Labour member of Parliament and told me about the intervention in the House of Commons by Alex Chalk, who interrupted the Secretary of State for Social Care, who used the opportunity to announce that, and I quote, the A&E will remain open and no proposals to close the A&E in Cheltenham will be part of the forthcoming consultation. Now, I've got to ask or pose the question, or we can discuss it if needs be, what does this actually mean? Whilst this news is obviously welcome on its face value, it creates a whole host of additional questions. Is it a full reprieve? Is the plan to downgrade Cheltenham to an urgent treatment centre now completely abandoned? Or is it on the back burner? Is there any chance that Cheltenham could return to a 24-hour A&E service? Was the A&E rationalisation part of any plan to provide a contribution to the Department of Health and Social Care's requirements, produce efficiency savings? Or will any other service need to be cut to meet this requirement? If indeed you have a requirement, I'm interested to find out. And D, how would this decision affect the other proposals to further centralise clinical services in Gloucester? And if this went ahead, could make Cheltenham A&E services unstable? However, one could take the view, and as a party political figure I can do so, that Mark Hancock's intervention may be just for the purpose of trying to retain Cheltenham in the next general election, and that he has no policy sustainability. We shall see. The Secretary of State has said nothing about whether any other proposed changes, such as centralisation of general surgery on Gloucester, is now off the table or not. It probably is not. Of course, reading it through, yesterday's announcement must mean that sections of the Fit for the Future document are now presumably redundant, and that much of the engagement exercise must be reconfigured. I'd welcome your views on that. I'm anxious to find out how One Gloucestershire will now proceed with this process. The proposals for the future of A&E services are intertwined with other changes to clinical services. We must be told as soon as possible about other consequential changes you may now have to make. I still want to make a few comments, however, as Flo did, that I would have in fact made if yesterday's announcement hadn't been made, because I still think they're relevant until we have absolute clarity on Cheltenham A&E's future, which I do not think we have. The proposal as laid out in the current document is to downgrade A&E service in Cheltenham, staffed by specialist emergency clinical nursing and support staff. It is my interpretation from the document that you wish, or may still wish, to close the A&E department in Cheltenham and replace it by an urgent treatment centre, which would, in my view, be unable to provide what is defined by the Department of Health and Social Care as emergency care. We believe that the effect of the change, if it has now come about to the people of Cheltenham and parts of the country, up to 120,000 people that are dependent on Cheltenham A&E services, would be that anyone requiring emergency medical treatment as defined would have to travel to Gloucestershire Royal Hospital, adding vital time to their treatment. And of course there are a number of other points that have to be made there concerning visiting, the access for people in Cheltenham, who may have limited budgets, the elderly, etc. Cheltenham Labour Party is opposed to the restructuring of A&E services in the county and believes it is a short-sighted policy proposal designed yet again to reduce NHS services and make savings at the direction of the Department of Health and Social Care. Moreover, as part of this engagement exercise, we are not only opposing this rationalisation, but would like to see the restoration of a full 24-hour accident emergency service in Cheltenham to replace the existing downgraded unit that exists from 8 to 8 a.m. the following morning. However, whilst Cheltenham A&E services are now apparently secure, and I use the word apparently in inverted commas, it does not resolve other issues facing A&E services in the county. If we look at statistics of waiting times in both Cheltenham and Gloucester A&E departments, they suggest to me that they have difficulty coping with the patient load. I took one day, figures supplied to me, on the 29th of September, just gone, in the early afternoon in Cheltenham, with a status of low risk. There was an 83-minute wait to be seen and 35 people in the queue. At the same time in Gloucester, with a status of severe risk, there was 139-minute wait and 69 people in the queue waiting to be seen. This is, of course, the waiting time to initial assessment, not the total time for treatment. The target for initial triage is 15 minutes and the target of completion of treatment is 4 hours. From what I know from personal experience, this is often the situation with Cheltenham coping and Gloucester at higher risk of missing its targets. The centralisation of A&E services in Gloucester would only have added to their problems. What we now need is for One Gloucestershire to tell us how they propose to resolve this issue. And Councillor Lucas, of course, as I heard, was quite clear and adamant on this, and I agree with everything she said. The proposals for reconfiguration of services in the two hospitals must be seen in the context of the proposal to move services from Cheltenham General Hospital to Gloucestershire Royal Hospital since the merger of the two trusts, with only a few moves in the other direction. We are reminded of the succession of changes in service provision in Cheltenham, weakening and undermining of service available locally. I shall refer to this again under my comments on the proposed centralisation of general surgery on Gloucester, which also forms part of this consultation process. Another area of concern is that with less surgical staff and facilities available in urgent treatment centres throughout the country, but not in Cheltenham and Gloucester, it will become largely a standalone operation. This could easily open it up for the possibility of being put out to tender and becoming operated by a private for-profit company in the future. We express our total opposition to privatise any of the current or future services and state publicly that it will be strenuously opposed. I think you know the Labour Party's position on privatisation in the NHS generally. Of course, I'm the first to recognise that A&E problems are exacerbated by the difficulty in members of the public being able to secure timely GP appointments. I know of a 4-week waiting list in some surgeries. One Gloucestershire needs to urgently address this issue as it impacts on A&E services in general, and it needs to be a major target for the clinical commissioning group to resolve this, and I welcome to hear what you may have to say on this. Now, finally, on the A&E issue, before I go on to general surgery, a personal comment. 3 weeks ago, I personally had the urgent need to attend Cheltenham A&E department as a patient, presenting with a severe urological condition. I want to put on public record my admiration for the highly professional and caring manner in which I was treated. Some of my colleagues, however, have said to me that this was taking my preparation for today's hearing just a little too far. I now turn to the question of the future of general surgery. I should at first declare an interest that I have suffered most of my adult life with Crohn's disease, and I've had innumerable colorectal operations, and I'm now heavily involved in representing patients in this field. I'm chairman of the patient liaison group of the Association of Coloproctology, a member of the board and chairman of the patient panel of the NHS's National Bowel Cancer Audit, and a trustee and secretary of the Bowel Disease Research Foundation, and possess a sound knowledge of the needs, I believe, the needs of patients and public in this area. Comprehensive training of surgeons is validated by the Royal Colleges of Surgeons, and now other Royal Colleges, since we have a Royal College of Emergency Medicine now, which offers them a wide range of skills which are essential for their role in an emergency. General colorectal surgeons are able to deal, for example, with wide variety of problems such as internal bleeding, bowel perforation, peritonitis, intestinal obstruction, and other life-threatening problems. While some of these emergencies arrive through the accident and emergency departments, existing inpatients within a hospital will develop life-threatening conditions requiring surgery. General surgeons also form part of the backbone of emergency cover for all inpatients within a hospital. We, in fact, are proud. I believe we have the right to be proud of the way we treat surgical emergencies. For example, the National Emergency Laparotomy Audit, of which I'm familiar, shows that patients presenting with surgical emergencies requiring major life-threatening surgery are treated with outcomes comparable or exceeding national standards. That's something to be proud of in Gloucestershire. I understand that One Gloucestershire is planning to centralise the care of all general surgical emergencies at Gloucestershire Royal Hospital, but it has not clarified its proposals for major planned general surgery patients. Does Gloucestershire Royal Hospital have enough beds to permit the centralisation of emergency patients to Gloucestershire Royal Hospital without a corresponding synchronous centralisation of all major planned general surgery to Cheltenham? We are owed an explanation that this proposal of immediate centralisation of emergency service would transfer all of the resident surgeons from Cheltenham and relocate them in Gloucester, a major safety issue for all other existing inpatients in Cheltenham. It suggests that there will no longer be a resident surgical registrar who can provide a specialist opinion for other patients at Cheltenham. Instead, One Gloucestershire is proposing that patients at Cheltenham General Hospital are covered remotely by surgeons resident in Gloucester who would need to commute to Cheltenham. Now, I want to say here now, something I've taken an interest in over the years, I have no objection or opposition to the creation of centres of excellence. I've seen it before, and where I worked before at Birmingham University, in fact, where I was sub-dean of the medical school, we achieved it quite successfully. But what I can't see here in these proposals is that we're going to get the right balance. And even if we create a centre of excellence, the gap between the two hospitals could create problems. Additionally, the resident surgical registrars at Cheltenham are integral to the ongoing out-of-hours care and emergency admissions to urology, vascular surgery, and gynecology cancer surgery patients here at Cheltenham. These latter three services are regional services, serving Gloucestershire, Wiltshire, Herefordshire and South Worcestershire. If these surgical registrars are removed from Cheltenham, the safety of these other surgical services might be jeopardised. We believe that the transfer of all emergency and major inpatient general colorectal surgery from Cheltenham to Gloucestershire, leaving Cheltenham to perform only intermediate and minor day case surgery, is a detrimental step. This would also remove the current out-of-hours general surgical cover from Cheltenham and, in our view, possibly jeopardise the safety of patients. Linked to this is the potential isolation of medical gastroenterology, which was centralised in Cheltenham only 2 years ago. As you know yourselves, medical gastroenterology in patients can deteriorate rapidly and require urgent surgical review and sometimes life-saving surgery by colorectal surgeons, and that has in fact happened to me in the past. Of course, with the survival of Cheltenham's A&E services, as announced yesterday, I believe, this may need to be reconfigured. Finally, some final more general comments for the record. In 1948, the Labour Party proudly created the NHS and vigorously defends it to this day. We are aware of what we believe lies behind many of the proposals we are discussing today are in fact detrimental to the earlier values that we put on the NHS. Of course, it comes down, I think, to an extent to money. In 2013, NHS England reported that it faced a funding gap of 30 billion by the end of the decade, assuming government funding kept pace with inflation. The government has provided for an 8 billion funding increase, but with the expectation that 22 billion in efficiency savings will be made. Efficiency savings, in our view, being a convenient expression for cuts and just the sort of service loss that I believe we're facing here in Cheltenham discussing today. The current government has promised additional funds for the NHS, but as the Nuffield Trust has highlighted only recently, over half of the promised immediate 1.8 billion was already in hands of the NHS Trust, with the Department of Health and Social Care ordering it not to be spent. We in the Labour Party believe that the future lies in investment of 30 billion over the course of the next Parliament, over and above what the 2013 NHS England review requires, and a halt, and this is something we're calling for, halt to the implementation of the sustainability and transformation plans, but perhaps that's for discussion another day. Thank you very much.
Okay, thank you very much, Professor. A lot of different subjects to talk about there.
Yeah,
Right, anybody want to open proceedings and ask a question or explore anything with the Professor? Yeah, Mark?
Is it going to be worse than Prime Minister's question time?
No.
Thank you very much. That was very interesting, and I could spend several hours, I suspect, picking over the bones with you on that. I'd like to pick up one of your latter remarks. You talked about your own experience of working around centres of excellence and that they'd been successful in Birmingham. And then you talked about you weren't sure that we were getting the right balance. So I'd like you to explain a little bit about what you mean,
Right.
What is right balance, how do we work out whether we're getting it and so on?
I remember looking into this. One of the things we had in Birmingham was that the fact that the major hospitals in Birmingham, the QE, Selyoak as it was, Heartlands and others, were almost in close proximity to each other. And therefore patients never had a problem of having to go to one patient for a particular course of treatment. It was on the same bus route, many of them. But of course here, I think in Gloucestershire, we've got a slightly different problem, because the gap between ourselves, say Cheltenham General Hospital, I just live in the corner from Bath Road, and Gloucester is quite a distance. And I've had it expressed to me on a number of occasions by people, particularly those who have difficulty perhaps finding the fare. The elderly, the old lady who's worried that her husband's in Gloucester and she's living in Cheltenham. And the other factor, of course, we need to address is the X99, a bus I use, because some of my consultant appointments are in Gloucester, stops at 8 o'clock in the evening. And that's unacceptable if you want to go and visit patients or have access to the A&E department. And perhaps that's something you need to talk to with the bus companies. I'm not opposed, as you say, Doctor, to the creation of centres of excellence, but I don't think it can work unless we get an established, unless we resolve the issue of communication and distance.
Okay. Yep. Yeah.
I'm again quite interested in what we can provide in the community, and I'm interested in what you've worked with in the past about community-based care before someone gets seriously unwell. What your experience is about delivering that care within the community.
Well, let me think. Well, it's something it's something I personally am very much in favour of course. I've always believed that two things. First of all, within the community, is readily access to general practice services, and I'm not necessarily saying access to a general practitioner either. I've always believed strongly in the role of practice nurses, consultant nurses within practices, and I've also believed actually, and I've seen it happen in some parts, the other parts of the country, that some general practices are now receive visitations from consultants who are the clinics in general practices, and I think that's something could work. But the other area which I'm actually concerned with and need to see develop is in fact more nurses within the community, not just based within general practices, but in fact, I'm old enough to remember Queen's nurses. Yeah, thank you. And the role that they played, in being within the community, and in fact an opportunity, for someone who's ill or within the community, and it might be a minor thing that a visitation from a nurse on one occasion just to resolve an issue might be all that's needed. I'll give you an example. As I think you picked up from my statement, I suffer from a urological condition, and the number of UTIs I get is quite legion, and I've needed antibiotics. A visitation from a nurse who's got prescribing rights, just to look at me and write me up a prescription for antibiotics, saves a lot of time, trouble, and money than it would be for a visit to a general practitioner. The other, sorry to interrupt you. The other, I've got the wrong glasses again. Is that of course the link between community services must have a strong link with social care. I mean, the Labour Party's policy on social care, I think, is quite well known. We believe, one day we would look forward to a national health and social care service. But there's one thing that One Gloucestershire needs to do, perhaps he's doing, and I hope I'm not insulting you at all, is to talk to the county council about how we can integrate more effectively social care, particularly social care within the home, not necessarily residentially, but within the home, and create a service that we can provide to make that better. Of course, as I said in the end, it requires money, and that's where us politicians start having a go.
Can I just ask you one more? Do you believe your constituents feel that a hospital bed is the best place for them, and do you think they consider other options that might be as good as or more cost effective and efficient?
Yes. Members of my party and constituents elsewhere where we do sit on local authorities have told me on a number of occasions they'd sooner be in their home. My medical students in Oxford tell me the thing you've always got to remember about hospitals, they're terribly dangerous places. And people recognise that. It's not anecdotal. You read in the papers all the time MRSA infections. I know we haven't in Gloucestershire. We've been very successful in preventing that, and that's all power to your elbow. But people would like, particularly the elderly, would like to be treated in their own homes. They don't like going to hospital. I don't like going into hospital. But if we could think and develop a service that can allow for that, and in fact, maybe even create a structure where we can have far more domiciliary visits by people of all the, by both clinical and professions ancillary to medicine, I think we'd be going a long way to achieve what we want, all around this table, including myself, would like to see the NHS that we want.
Thank you.
Mark again?
Can I ask another question? I'll defer to colleagues. Given your background in global health policy and UK health policy, and given that this is a One Gloucestershire engagement, we've spent an awful lot of time talking about A&E departments and acute services, and you'll know as well as anyone else that the way to improve the health of the population of Gloucestershire is to left shift into prevention.
Absolutely.
And I'm interested in your thoughts about how we might do that and how we can, shift a little bit of the momentum in that direction.
Prevention of illness and health prevention, and I've been involved in this overseas, comes down to what's particularly in India where I work, really comes down to education. We can do things like stopping smoking. We can do things like healthy, things that politicians can do nationally about, taxation on fizzy drinks and things like that is one thing. But I'm just wondering whether, in fact, why can't the NHS, for example, be allowed to go into schools and talk to school children at length about the dangers of things that they're facing. Also, of course, health prevention comes in other areas as well, and it's part of the climate change arguments or discussions we're having at the moment. In India, of course, the biggest threat to health isn't smoking. There's very little smoking actually in India. It's air pollution. I live in the middle of Cheltenham, and it's not the most polluted place on earth. That's a long shot. But of course, whole areas of climate change and issues relating to environmental health, I think, are some things that we don't get to grips with. In a nutshell, as I say, it goes down to education, and how can we, and we're delighted to help you in any way we can, how can we together and push forward that agenda? What ideas do you think we ought to be doing?
I suppose I was trying to get at the way in which the health services and the local authority services need to work together around this agenda, and your thoughts about how best to do that. Whenever we talk about health, we end up talking about hospitals,
Absolutely,
rather than about the health of the population.
Go back to the point I made. CCG and the trusts talking to Gloucestershire County Council about an education programme. I don't think at the end of the day, and it's the same with a number of issues, such as climate change, and widely known my party has applauded those school kids on a Friday, but they're the future of this world, and unless we get into schools and talk to the young people at a certain age, and too young is not late enough for me, I don't think that we will in fact achieve that change that we want to. We've got to talk to the county council and get them to agree to it.
Okay.
Before questions, just wanted to a point of reassurance. So a couple of times you mentioned finances. So I just wanted to make the point this is not a financially driven programme.
That, yeah, but
this is about sustainable, outstanding services for Gloucestershire and the residents of. And the second point was around process. So we are in that engagement and consultation stage, which is about defining that future state, so that clinical model. And then once we've gone through engagement and consultation to get the preferred solution, then our attention changes to, okay, how do we implement that? So making sure we have got the right beds, wards, theatres, critical care in the right places, and only then do we start to move into implementation. So this is not a, let's make some quick changes now, because you're right, the two sites couldn't cope. So it's about a longer term vision and then a proper planned approach to making sure those facilities and workforce are in place.
I welcome your assurance, and thank you very much for that. Can I ask you a question, if it's not too pertinent of me, Mr. Chairman? In preparation for today, you obviously found yesterday's announcement in the House of Commons as surprising as I did. How do you? I asked this in the paper. How do you think this engagement exercise can or will change now that Mark Hancock has said Cheltenham A&E won't close? What does that really mean to you?
So to kind of welcome that, really. So it's a helpful statement, because we've been consistent throughout that's always been the position. Yeah. So what we kind of hope now is that the discussion can move on. So as we've just done now, we try and discuss a bit more about what the Centres of Excellence mean and what does community care mean. So I'm hoping this is a bit of a change in the programme that we now move on.
Yeah, but will the preservation of, there's going to be knock-on issues, of course, if the if the Secretary of State had said Cheltenham A&E will remain, obviously it throws some of the issues that you're published in this document slightly out, and obviously we'd be interested, not today of course, but we'd be interested in the future to see how that ministerial decision affects the process in your thinking pattern.
Yeah, I mean, it is interesting. Just as an extension of that, having read that booklet, the emergency department is part of a wider issue of access to urgent care, and I think that from what I understand is the position is on that is to continue to explore and listen to people's views on it.
Absolutely.
So,
I'm in Cheltenham. I live in Cheltenham. I represent Cheltenham Labour Party, but I know throughout the county and other parts they're anxious about the future of their existing urgent treatment centres, or even the lesser centres that exist. And of course, on their part, this process must continue because we've got to find a solution to what I'll call A&E care throughout the county. Through this process, not just saying Cheltenham is safe, so I'll pack up. I live in Cheltenham. I represent Cheltenham Labour Party. I'll pack up and go home. No, that's not the case.
I'm just curious from your experiences as well, and I'm assuming that from what you've described as your experience, you have been through the processes of having to relook at models at given points in time. In processes that you've been involved in, what balance and what kind of perspectives have been taken on involving the public in helping to arrive at decisions and getting people involved in all the different processes you're taking place, versus looking at things purely from the expert's perspective?
Yeah, that's an interesting question. I mean, I've seen this document. I remember when it was published. You have in fact created a number of structures. You had the visitation, the lorry with the visitation. You had a series of workshops, one of which I attended, and I was very grateful. In fact, that opened my eyes to a number of issues which had concerned me. I went to the one in Churchtown, and I'd like to thank you for that. There's today, but of course this is just another part of this process. How do we involve the general public? My worry is that not enough. I mean, you might be able to know this, but the sort of the questionnaire in here, I worry about how many people have responded to it. Are we doing it in the right way? Are we using social media, for example, to bring these questions out? Not just a sort of tear-off slip in the back of a booklet, which not a lot of people have in fact seen. Should we be doing it? I'd like to see. This is so important, healthcare, for the future of healthcare, for the people of this county, and we're all agreed on that. I'm not seeing adverts at bus stops, posters at bus stops. I'm not seeing other things. I'm not seeing on Facebook yet. Maybe I have. I'm not a great Facebook lover, actually. But things like that. You could, I think, explore it widely. And of course, the other area, which if people will come, is what we loosely call town hall meetings. They're never in town halls, but we call them town hall meetings. About calling the people together and telling what you're doing and what do you think about it. My neighbour and your neighbour, I'm afraid, all they hear is what they hear on the newspapers. Like they're closing Staffordshire. I'm sorry, I was on the bowling that the other day. They're closing Cheltenham A&E, and it's bad, isn't it? That's not the issue. The issue is much wider. I'm personally now Matt Hancock has decided I'm particularly more interested in the general surgery and getting the balance right between the two hospitals, so people aren't seriously affected, and that we have a sufficient medical staff to contain all eventualities.
Obviously, part of what you said today is a personal opinion in some respects, and also you've talked about the Labour Party position.
Yeah.
I'd be really interested to know what the Labour Party position is on the shortage of medical professionals across the UK and how that impacts on people in localities like Gloucestershire.
Oh well, we're getting it. Yeah, I mean that's a real issue. I mean, I'm associated very strongly with the Oxford Medical School, and and I talk to my 60 students about who are about to go in to become doctors, and there is a doctor shortage. If I can make a political point about this, Brexit isn't going to help. We need to encourage two things: expansion of medical schools should it be needed. Second thing, expansion of medical speciality training. And thirdly, if necessary, importing more doctors from overseas. But that itself has a problem, because when I go to India, the first question is, how can I come and work in the NHS? It's all very well, but who's going to look after, the patients in the state of Bihar where I'm working and trying to improve healthcare? It's a terrible balance. But there is a shortage of doctors. I think there's a deprofessionalisation of doctors, which I deplore. I remember I was on a Royal College of Physicians working party some years ago looking into that. And how do I put it? Unless the government can get to grips with that issue, and it's largely financial, you can't just say we're going to have more doctors without putting the money behind it. That is a political decision, a political decision we in the Labour Party are fighting, for the government to make. If we were the government, it might be easier, hopefully.
So yeah, okay, I can see that. I mean, but does that mean then that from the party's perspective, when it comes to a situation where you've got to reorganise in order to maintain the quality of services or perhaps to improve them, that you also have to deal with the compromise of perhaps not having enough people?
Well, yes,
and
of course.
Where is the borderlines between the things that you do and you don't do? Is there any positions on that sort of thing?
Well,
and from your perspective, have you a view on it?
I mean, I don't want to be a hardliner and say, the NHS has got its basic hard, and we're going to draw the line there, because you can't do that. Because in Gloucestershire, we've got patients to treat. We've got people to look after. Those involved in clinical and professions ancillary to medicine around this table and know that. But so I'm happy to discuss issues. I mean, if I didn't think that we could help and collaborate and cooperate with this exercise, I wouldn't be sitting here today.
Yeah.
I'd be saying, I'd be standing outside with a placard saying, cuts,
Sure.
stop the cuts, and they're all talking rubbish in there. No, that's not the case.
Yeah.
The case is that we need to compromise, but at the same time, we must ourselves jointly, and other political parties as well, Flo, I'm sure would join with me on this, is that we must work together to ensure that financial resources are made available, and that we and your staff you can appoint enough consultants to give a proper service.
Okay. Yeah. Right. I'm just conscious of time. Any last questions? Quick one. Yeah. Sorry, Julie.
No, it's okay. I think the moment's probably passed. I was really interested in your experience about what you see as the benefits of the Centres of Excellence for Surgery model, particularly for Cheltenham, in terms of less cancelled operations, perhaps better improved access. So I just wondered if you, particularly having had the Birmingham experience, I've had the privilege of working as well.
Yeah, I mean, the Birmingham experience has been different. I mean, I was thinking particularly, and you remember this, when you had the QE over there and Celio over there. There was a split in services. This ology was over there and this ology was over there, and it worked particularly well. I'm involved through the National Bowel Cancer Audit and looking at surgeons' death rates in particular trusts. And one of the things we've noticed is that where you have a centre of excellence, you have a much better level of treatment. I mean, say for example with bowel cancer, with treatment of surgery on bowel cancer, you're able to subspecialise within a centre of excellence. Something if you've only got 2 gut surgeons, say in a DGH, you can't do that. But where you've got 15 in a centre of excellence, you can do that. And if you've less, and yourself, unless you're a surgeon and you do at least 5 of these operations a year, they tell you not to do them. So it's something I'd like to support, but in doing so, it's something that I feel that unless the distance between Cheltenham and Gloucester is an issue, unless we can resolve that in some ways, it might be to do with car parking charges, it might be to do with bus services, it might be to do with getting the balance between which service is where, right? I know, for example, and it would churlish of me to say that you have concentrated cancer on Cheltenham, And I know that a lot of people have found that including my wife, has found that very, very beneficial. I'm rambling a bit here because it's a difficult one, and I'm trying to say that, centres of excellence is something that long time are coming, and it's also good, of course, particularly good for clinical teaching, both the juniors and of clinical medical students. But I'm continually told by patients that I don't want to go over to Gloucester, it's too far, I can't afford it, I can't get there, how am I going to get back? You've got to give people assurances that you can resolve that issue.
Yeah. Okay. You've got the last question.
Professor, you touched on the date of 29th of September and the various waiting times,
right.
which is the average time to be seen in the two departments in Cheltenham and Gloucester. You touched on briefly that the national triage standards, so if a patient walks into, an undifferentiated patient walks into A&E, they will be seen and triaged by a senior nurse within 15 minutes with a standard to be treated within 4 hours. I just wonder what your thoughts were on, obviously, a patient, I may wander into A&E, I would be seen within 15 minutes. A lot of patients then, it's a sort of pressure cooker in A&E and a sort of bottleneck in the system. If that patient is deemed actually, you could wait till tomorrow, you could wait till the next day. You have turned up and you could join the 4-hour queue, but you will be clogging it up. Would you advocate, or would your residents advocate an increasing number of patients being redirected to another service, pharmacies in the community, to see their GP, a routine appointment, the minor injuries unit?
I mean, I speak from experience. I've only turned up at Cheltenham A&E a few times. But I know you only too well, mine have been an A or a B, a category or a category B condition. I've always been concerned. Like you sit in the waiting room at the A&E department and you see people there, and you mutter to yourself, I say this quite candidly, should they be there? I don't know. But then you say to yourself, but some of them haven't got any choice. I heard you talking Flo, about at the end of the thing about what you have in your surgery, about urgent appointments. But I do know of general practice appointment surgery. I'm not going to name them because it'd be improper to do so. Where there's a 4-week now waiting list for general appointments, and sometimes you ring up and you cannot get even an urgent appointment on that day because they're all full. The duty GP, is got full, and we've added 2 more on. So these people's only alternative is to go to the A&E. Yes, you're right. I mean, more people should, I think pharmacies are underused. A number of areas, I always make sure I go to my pharmacy to get my flu jab, for example, and things like that, and by supporting them. But yes, we could do that, but of course people have got to be assured in their own minds that, I know it's a difficult one, but particularly the elderly, I want to see a doctor. Nothing else will do. Until you can get people educated to see that there are other professions ancillary to medicine that can provide such a good service, it's there. They are there. Practice nurses, consultant nurses, dare I say, and it's not always a popular thing, but I was involved in the start of the process in Britain, physician's assistants, and things like that. They're all there, out there, and they can do a good job, and most of them have prescribing rights.
Okay, brilliant. Professor, thank you very much. It's been really enlightening and very, very useful as well. And it's good to listen to your experiences.
I will make my statement available. I was sitting downstairs in the bar finishing off about 10 minutes before I came up here.
Okay.
What academics do.
Yeah.
But I will type it up and I'll send it to Becca.
Brilliant. That's fantastic. Thank you very much indeed.
My pleasure. And I hope we'll all get there together.
Indeed. Okay. So I believe that our next presentation is from Tony Foster, who's a Cheltenham resident, and I think we just got to mic you up, haven't we? So yeah. Just while they're doing that, we'll have a little kind of discussion. I mean, I don't know. One of the things that seems to be a recurring theme at the moment, or coming back to a recurring theme, is the issues of education and access. outside of obviously the services themselves. So it's one of those things that perhaps we'll look at as part. You might want to look at as part of the programme, really.
I also think it needs to be a bit broader than that. We need to
Yeah.
look at the plethora of other things that are available in the community at a much lower level. I think we're always looking at the end point and not at the beginning of the journey and what is out there.
Yeah.
I don't think I'm hearing that the presenters today have really have been informed about what's available in their community. And there's social care, yes, but there's a whole host of providers doing things out in the community.
I think our presentations, over the 7 presentations around the localities, made efforts to achieve that, but I do agree with you. I think we need to get that message out. So that very sort of diagrammatical picture of almost 5,000 appointments a day, urgent appointments a day in GP practice, I don't think